Hey, welcome everybody again to these neonatal lectures. Today it's a great honor to introduce Doc Blank. He's from Melbourne, but originally from the USA, and he came here as a neonatologist, but also as a fellow in the Ritchie Clinic, where he did numerous studies, which were all related to resuscitation of the newborn. And we know him from his original work in delayed cord clamping, but also different methods to address a baby who needed to be resuscitated, different medications and doses and ideas about resuscitation, which is quite interesting sort of work. And today, Doug is going to tell us about, well, what if you just video the actual resuscitation? What can you learn from that? And how can we improve our skills, I'm assuming. So I'm equally interested in your talk today, Doug. So over to you.
Thanks very much, Kurt, and thanks for the invitation, and thank you to everybody who's joined. I wish to acknowledge the people of the Kulin Nations on whose land we're gathered today, at least at Monash, as well as the traditional custodians of the lands that you may be joining us from, presumably across Australia, New Zealand, and elsewhere. I pay my respects to their elders, past and present. And so the title of this talk is Every Sports Team Uses Video Review. Why don't we? Lessons learned from Neonatal Resuscitation Video Review. So this is going to be a talk about a QI project that we have at Monash that's been ongoing for a few years. I'll get into more of the specifics, but essentially videotaping and reviewing resuscitations in a debrief and educational format, and some of the benefits of this and how I'm hoping to expand the program and the overall effort. It's good to start with a quote. This is from Colin Marley, who's one of the godfathers of neonatal research in Australia, really with a specific bend towards respiratory and resuscitation. Helped build up the really robust program at the Royal Women's with some contributions to some of the works that's been done at the Ritchie Center as well. And his quote is, neonatal resuscitation is like driving or having a sense of humor. We all think we're good at it, but we really don't know. So there'll be 4 sections to the talk. We'll talk about cases and video review, both inside of neonatology and outside. We'll talk about neonatal resuscitation video review, or NRVR, for education, NRVR for research, and discuss whether or not NRVR is deemed to be effective. So, all right, so critical cases and video review. The first one is a 17-year-old wrestler, circa mid-90s, who seeks redemption after loss to a rival, having had the match videotaped and reviewed in a debrief session, one-on-one with coaching. This wrestler, who might look familiar, was able to defeat his rival on the rematch. So from that point on, I was hooked on the utility of being able to review my own performance in what then was, although trivial and essentially mediocre level of sports, was still for me a very important a task that I had to attend to and wanted to improve. The second case is way more critical, and this looks at the benefits of review and debrief, enhanced review and debrief. This is Captain Chesley Sullenberger, or Captain Sully, who is the title character for the movie Captain Sully, which was played by Tom Hanks, and his Miracle on the Hudson, in which an airplane loaded with passengers in winter took off from urban New York City, immediately had engine failure, and Captain Sully was able to land the plane safely on the Hudson River in the middle of the city, in freezing temperature and freezing water temperature as well, or cold water temperature, and 100% of the people who were on board that plane were able to leave in relatively good condition and survive. And then the third case we'll go over is an example of a first-year fellow leading a neonatal resuscitation. This is in University of California, San Diego, where I did my clinical training for neonatology before moving to Australia. So we'll start with the third case. So this is intended to get your pulse up a little bit, and a very typical review of a neonatal resuscitation that would be an excellent candidate for teaching. I'll play the video in just a bit, but just as a precursor to know, this is a 24-weeker, adequately grown, well-grown baby boy born because of maternal indications, again, just over 10 years ago in San Diego. A planned cesarean section delivery after daily Doppler assessments and daily monitoring on mom with antenatal steroids on board. Good fetal heart trace prior to delivery. Essentially ideal conditions, if there is such a thing, for a 24-weeker to be born. What you're going to see is you'll see and hear the resuscitation on the video above, and then the top graph shows heart rate on a scale from 0 to 200. The next graph in blue shows sats from 0 to 100, and then the inflation pressures. And you'll see this purple and then yellow line scrolling across the screen on the x-axis with the time points down here in 45-second intervals. So something to note is the baby's condition at the beginning of the video. It'll be about 2 minutes. So here we go.
All right, I'll lift baby. Okay, someone take the blanket off.
I got it.
All right, let's wrap. Switch the mask. Starting PPV.
Heart rate's less than 60. Heart rate on the monitor 55.
Heart rate's under 100.
Heart rate 68.
30 over 5, 21%.
Long breath. 1, 2, 3, 4, 5. 1, 2, 3, 4.
1 minute.
1,
Heart rate
2,
70.
3, 4, 5.
That's 51. PPV, 30 over 5.
We're still within the TOTS range. Okay, we're just gonna gain some color.
I feel like our
Right on the top. Okay, let's go.
our EKG is picking up nicely.
It's okay with the TOTS.
The leads are good?
The leads are good?
Yeah, the leads are good.
Okay.
They're at 84.
Yeah.
You can listen.
Heart rate 78.
Let's go up on the
We're
pressure.
at 40%.
40
That
over,
rolls on.
40 over 5. Pressure's 40 over 5. We're starting to get good color change on the PD cap, still on 21%.
Oh, 21% or 40%?
40%.
Quartz clamp.
Heart rate 72. Our heart rate hasn't gone above 100 yet.
83%.
Yeah, let's go up on the, go up to 60%. 60%. 60%.
Jackie, you're okay. The leads are protected really well.
The leads are good?
Yeah.
Yeah.
Can you put it on the baby?
Yeah.
There we go. Our heart rate 81, 87. Yeah, heart rate's 94, 102.
Okay, so there's a lot to unpack on this video, but again, it was meant to show you a typical advanced resuscitation, and there's a lot of things that were done really, really well. Great examples of how a team should interact with each other. Lots of closed loop communication, methodical movement through an algorithm, which might be different than the one that you're using, as far as the progressive steps, but there's clearly a plan. There's still other questions that you can gather from this besides just the overall review of how the team did, how the baby did. You can see clearly in points in time which interventions of going up on oxygen, going up on pressure, how that correlated to increases in heart rate and sats, technique of how the mask is being held, is the baby being properly managed from heat loss. One thing that was curious at the beginning of the video was how this baby was placed on the resuscitator, breathing, crying, vigorous with good tone, and then quickly the baby became apneic and bradycardic. So while I was a fellow in San Diego, I trained under someone who's kind of a counterpart in North America to Colin Marley named Neil Feiner, and he and Wade Rich had set up a resuscitation video review program that we've modeled ours after here. He and Wade are both retired now, so the program's dissolved a bit. But I had the luxury of having videos like that presented in front of the whole faculty every 2 weeks on the largest and highest definition television screen available at the time, which sounds a bit punitive. It wasn't meant to be, but certainly was extremely honest. And we'll go into some of the aspects of how that confers an advantage for trainees and people who are permanent NICU staff, like most of us are probably on this call. So the lessons learned from both Captain Sully and Feiner, Professor Feiner, about having to prepare and to perform in an emergency situation are that experience and training are paramount. And with neonatal resuscitation video review, you get more virtual repetitions. So at Monash, we have about a 60-bed unit and 12 plus fellows and about 12 consultants. And typically 2 consultants or 2 fellows don't occupy the same space at the same time. So if you're going to only be the primary person or part of one of the people who's primary to the care of about 10% or less of the high-risk resuscitations, there's a need to be able to put yourself in the driver's seat and get experience, albeit virtually, with the other resuscitations that you don't get that experience with. Plus, it gives you an avenue to see what other people are doing well, what they could improve on, and how you could potentially incorporate that into your own practice. Second point that Captain Sully said about his ability to land the plane in the Miracle on the Hudson was that he had training that allowed him to stay calm during emergency management. Now, I don't think you can just say stay calm and just do it. Staying calm is a result of having a plan, anticipating the next steps, and having experience with reassurance of a good mechanism to understand if your performance in that situation was the right thing to do, and how to correct course. So with neonatal resuscitation video review, you have the ability to observe novel situations. You have the ability to observe yourself performing in these situations. And I can tell you personally that I was not calm at all when I started attending resuscitations as a leader. But because of the video review, I've gotten way calmer, and it's really helped with that kind of training. Clear communication in emergency is paramount. That video was a good example of clear communication. Not just the leader of the resuscitation, but the nurses, respiratory therapists, they were all demanding closed loop communication. And you would hear, and most of the communication was very poignant and necessary. There wasn't too much extraneous communication. And so NRVR gives you the ability to evaluate how you are communicating and how other people who are communicating well do it. I tend to speak more than most in these situations, as I do in most situations in life. And so I've learned to pare down the amount that I say during resuscitations. Most people have the opposite situation where they're not necessarily letting the rest of the team know what they're thinking and could improve with that. But until you see yourself on video, it's hard to know. And until you see an example of somebody doing it well, it's hard to create a model for how to communicate. Following the list, specifically, were we prepared? Did you have all the information you needed to go into this resuscitation? Did you anticipate what could go wrong and how to adapt to it? For a lot of our patients, it's just following down the algorithm of NeoResus or ILCOR, ANSCOR guidelines, NRP, whatever your institution's using. But there's also cases where there are bursts that have to go off the algorithm a bit. If it's a difficult airway, did you bring in a supraglottic airway? Did you consider draining a pleural effusion prior to birth for high drops? Did you bring a video laryngoscope for a CDH? That type of preparation was the right team there. Did you bring surfactant down? Myriad of questions you can ask that are case specific and don't lend itself to a one-size-fits-all type of algorithm. And also, does the list need to change? So the algorithm the algorithms that we use are excellent, and they're based on a decent amount of evidence-based data, but I'm constantly in the business of trying to make improvements and filling the gaps of the evidence that's lacking for neonatal resuscitation. And video review gives you a great perspective of what potentially needs to change, which we'll get into in a bit. And then teamwork is critical. So NRVR allows you to incorporate the information provided, because there's a lot coming at you in a short period of time, even if our algorithm isn't the most complex compared to other emergency management situations. Understanding what other team members are doing during the resuscitation and how to perform those tasks, as well as you can perform your own tasks, is going to help with leadership, and vice versa. And we'll touch on this later, but having the ability to step back and see how the other people are performing and what their tasks actually entail to be successful has allowed me at least to understand how to better facilitate good teamwork. Okay, so this is case 4. This is a Monash resuscitation video example. This is in the context of a trial called the PINK trial, which is providing respiratory support to babies who have a congenital diaphragmatic hernia prior to umbilical cord clamping. There's a lot of really good lessons from this video. Almost all of them are positive. So I'll play the video clip. For what it's worth, the baby is being resuscitated on this purpose-built platform called the Concord table, which allows you to provide support to a baby before the umbilical cord's clamped. And you'll see the video laryngoscope screen on the top right of this box. For what it's worth, the top 1/3 of that screen has been cut off by the video, so the view that the clinicians can see is better than the view we'll see. But anyway, I'll play the video, so here we go.
Oh, hi.
Come a bit closer if you can. Yeah.
Yes, I'm going to need suction from this blade. Yep, I'm going to need suction. Probably going to need to go this way a little bit. Alright. Probably going to need pressure. Yeah. Okay, suction. Suction.
Yes,
On.
have your phone.
Can I get new chest leads?
For you.
New chest leads.
Okay, suction again.
Yep.
Suction.
I can't really get a very good photo of my life, but
Okay. Okay, there we are.
That's pretty.
Page. Towards tube.
you just got to wait for the tube to go in, and then we'll get a picture of the space. Okay? Once we get it,
Can I get some tripod pressure, please? Yep.
just below.
Just want a bit up. No,
Yeah.
you know,
Okay.
something.
Yep.
Yeah,
Brilliant.
yeah,
Good.
yeah.
Advance.
Excellent.
Yeah. Yeah. Tube's going in. Yeah.
Perfect, perfect.
Okay. So
Alright,
you need to
that's
cap.
that.
Starlighters out. Heat cap. Thank you. And T-piece.
And 10 at the gum. T-piece.
Here.
There's yellow colour change on the pedicab already.
So again, I could probably spend about an hour just going over those 2 minutes with a group of learners in a teaching session. A lot of really good, a lot of great examples of how to do, how to function well in a highly stressful situation. One thing of note is that you could see how the table rolled up close to mom and the baby was placed on the table, and then through nobody's fault whatsoever, the table slides backwards because the floor is uneven. And you can see there's just a little bit of stretch on the cord, which is may or may not have affected the advantage potentially gained by resuscitating on the cord, but at least provides us with the understanding that this actually happened, because I'm not sure anybody would have noted that because they're so focused on their own tasks that the bed did slide backwards, unless you had the hindsight of video review. I would have loved to have had this video when I started my clinical fellowship in San Diego because the first week of my fellowship, we had 2 babies born with CDH. And then I didn't see another resuscitation birth of a CDH baby when I was on service as the primary fellow until I had finished my clinical fellowship in San Diego and moved here and was a clinical fellow at the Royal Women's. So other good examples of tips for resuscitation that are not going to be obvious from any algorithm or any book reading was the amount of suctioning needed to happen in order to see the cords properly in a baby who hadn't breathed yet, or which is not the typical setup for us to be intubating these days. The video laryngoscope screen was not visible to the operator. She could see, she was using direct visualization, and then the consultant and the nurses that were supporting her could see the screen, but the use of the video laryngoscope was great because everybody could see the tube going in and could help adjust the airway, adjust the positioning to help guide the tube in. And then just the overall calmness of a team that was well prepared for with a plan and contingency plans in place was just jumps right off the page at you. So this would have been an excellent example for anybody of how to properly lead a resuscitation. Okay, so now we'll switch gears a bit to discuss NRVR for education and talk a little bit about the nuts and bolts of the program that we have in Monash. So since September of 2019 ongoing, we've had a waiver of parental consent via a low-risk ethics pathway to video record any neonatal resuscitations that are thought to be high risk, focusing on babies under 32 weeks or high risk like CDH or high drops, etc., even code green C-sections. In accordance with Victoria standards for a low risk ethics project, all records need to be maintained securely for 7 years. This is an example of what our current video will look like after processing. So not to get too much into the weeds on how this is done, but because this is we've adopted more newer technologies and gotten a little bit better. There's an ongoing process to improve how you capture videos and present them. But now we're using one GoPro camera that's a mini. It's very small. It's about the size of a pager. And we have metal surfaces attached to our resusciteers and a magnet on the back of the GoPro, so you can just clip them up to all the Atom cots. We have these metal plates on all 18 of our Atom cots, 17 of our Atom cots around the hospital, because at Monash, a baby can be born in 20 plus locations. The other way to run one of these resuscitation video review programs is to set up a fancy system in a single location. Places like the Royal Women's, or when I was in San Diego, could take advantage of their resuscitation room where they stabilize the babies with an outfit like that. But anyway, the cameras and the wide angle view has gotten so good that this is the raw footage of what a resuscitation recording would look like, where just from this one camera, you can see the APGAR timer clearly. If you wanted to, you could focus in on the FiO2 and manometer for providing pressure. You can see the baby clearly. You can see people clearly, which it's then cropped and cut. You can see the monitor. And if you have something like a video laryngoscope, typically you can see that screen as well. This eventually gets processed and cut down so that you can't see identifying features of the people on the video, except for their hands. You can hear their voices. And then you can see zoomed in views of things like the monitor and the video laryngoscope screen. So as far as consent from the clinicians who were captured, clinicians on the video may decline to have the videos recorded. They also can decline to have the recorded videos used for learning. I encourage anybody who's feeling unsure about it to view the video individually before providing their consent to show it to the wider group in education sessions. There's also the option for showing the video without voice muted. And we follow the similar principles to simulation training, which I lifted directly from the RCH Simulation Center, and I believe that's originally from Harvard, which states that participants both in the learning sessions and on the screen are smart, well-trained, doing their best, want to improve, and anything during those sessions is confidential. Verbal consent is what we use for the clinicians. But when you come to one of these learning sessions, their sign-in sheet is a consent sheet. So you're consenting to these, to agree to these principles. So far, in the last few years, there's been two main principal uses of these videos. The first one is for JMO teaching with occasional session for the nurses, which I want to expand on that latter teaching opportunities for the nurses moving forward. But anyway, and my goal is to capture 1 to 2 eligible resuscitation videos in a month and teach 1 session per month. That's been the goal for the last 4.5 years. So far, we've captured over 120 eligible recordings. There's been 42 different recordings taught. Once you have a recording that packs a lot of lessons, it can be reused. Often you're getting different JMOs at different sessions. We've done 64 learning sessions. The majority of those have been JMO group sessions for JMO learning, like the 1 to 2 kind of teaching. We've done 9 group sessions for the nurses. Again, double staff time, similar approach as the JMO sessions. 8 mixed group sessions is what I've been calling these. So working groups like our resuscitation and respiratory working group at Monash or a consultant meeting, etc. And then 12 people have taken me and others up on the opportunity to review the videos that they've been on in individual sessions. There's been 420 people who've signed in or participated in one of these sessions. Some of these people have gone to more than 1 session. A lot of them have, but 420, I guess, different people events. The other use for the video review program so far has been that Rishabh Bhatia, who's now the director of the women's and left us sadly just a couple months ago, started incorporating a 40-minute string of videos that are good examples of key items from resuscitations into our advanced neo-recess program that we provide twice a year to the Monash Health employees. And she started that in August 2020. There's been over 350 advanced neo-recess students that have seen that 40-minute clip of videos in advanced learning sessions. So that's a very good use. Okay, so I wanted to show another example of the video. This is an example of a neonatal anesthetic code blue response to a baby that was born hydropic and had a difficult airway. I'll just play the video. Again, it goes about 2 minutes, but it highlights some novel situations that unless you were there, it would be hard to get much context of what to do and how to do if you find yourself in a similar situation next time. So play the video. It's going to pick up about 10 minutes or so after this baby's been born.
35 and 5 and 100%.
Hello, can you call me back in about 5 minutes? Thank you. Bye. Okay, let's have another look now. Thank you. That's very, very, very not normal.
The other thing that's preoccupied is
Hey Joe, this is quite abnormal.
For the heart rate?
Abnormal.
Sats. Heart rate 130.
You can let me know when the stats drop, guys. Yeah, it's very stiff. I can't really get around the corner, and I can't really get a good view either, despite putting some rolls behind the shoulder. Should you fair out there?
Yes, we have an
Go
element.
Just size 1 will be fine, thanks. Pick that and just see if that moves. I'm not confident that's in.
Yeah.
Handicap on.
Open it up. Give it a loop.
Show me that.
Fingers on the way.
I don't think that's in. Sats are going down. Let's go back to bag mask ventilation.
We have, yeah, we're leaving up the elevator.
We had a gasp. No chest rising forward.
No, I don't think so. It sounds like, you reckon? No, it sounds like stomach coming out, bag mask ventilating. Chuck that in.
Small little mouth.
Yeah, no, everything's just very abnormal there. It's very stiff. That's better. That's good.
Go to gastric tube, please. 10 French. I already have an 8 in there. 8's fine.
Yep.
That's better. Some air moving. Good. Good job.
Is that EKT? It's really hard to hear the heart rate. Do you want to have a go?
Where's your Peter cap?
Element. 27 sat.
Yeah, that's good. We got CO2, we got a airway. So have a look at that. That's just
Okay, so a really great example of how to troubleshoot a difficult airway. A number of other lessons in this video that we can discuss, but that was just a prime example of a very novel situation that you might find yourself in once every few years and how to react to it, but certainly gives you a picture of success of how to troubleshoot that difficult situation. And certainly with the hindsight of a video, I think I'd feel much more prepared if I find myself in a situation that these brave clinicians found themselves in this video. Okay, so let's talk about NRVR as a research tool. The use of video review that we have consent for is again educational QI, but that doesn't stop us from developing hypotheses of what we should be looking at and studying next. Of note, if we do want to use the videos for, say, a retrospective review, like the example in this video that I'm about to explain, that requires a second application to the ethics committee, which we've done twice or 3 times. I think twice, sorry. 3 times, sorry, 3 times, but I've published one with one in press currently or in submission. So yeah, 3 times, and it's generally been fine. So this is an example of the use of a PediCap for mask ventilation. This was the first paper, example of the first paper that I ever published, which described how once end-tidal CO2 is detected during neonatal resuscitation, that will predict that the heart rate and SATs will come up quickly in a baby that's bradycardic and hypoxic. And the reason for that is makes sense physiologically, that the fetus depends on the placenta for gas exchange, for getting in oxygen and getting rid of carbon dioxide. And then after birth and after the clamping the umbilical cord, that responsibility then falls on the lungs. And so most of what we're dealing with during neonatal resuscitation, in fact, nearly all of it, is getting the lungs to aerate properly and gas exchange to occur properly. And that will improve cardiac preload and cardiac output as a result, resulting in an increased heart rate. So here's an example of the PediCap. And I also want you to pay attention, it should be about a minute clip. I also want you to pay attention to what the baby's doing during this clip. So I'll just play it.
We'll go up to 40.
So 3 minutes in, and an extreme preterm baby who is still bradycardic and hypoxic.
Want you to get rid of the intubation? Yeah, you get rid of the intubation stuff. I'll take over here. Yep. The heart rate will come up now. Okay, so 3 minutes, 30 seconds. Heart rate is 80 and rising. We're doing 40 over 5. There we go. Give a second, let the heart rate come up and the stats come up. We just get the 2 ready. Okay.
Now this is a clear example of the first time we saw PediCap color change, which has a minimal threshold of about 15 millimeters of mercury of exhaled carbon dioxide to provide that color change, and the speed at which the heart rate will increase. And this pattern of heart rate going from just above 60 to 150 beats per minute in about a 30-second time frame is pretty typical. I'm unaware of any algorithm out there that describes how quickly the heart rate should come up with the baby's bradycardic, but it happens very, very quickly. The sats don't always rise this quickly. In this case, they did, but typically they follow on their same sort of methodical linear increase in the typical situation. This baby was on 100% oxygen. When we left the delivery suite, or the operating theater in this case, the team was convinced that it was the change in operator that made the difference for getting the baby's heart rate up with non-invasive PPV. But in reality, when we changed operators and the baby was repositioned, the baby took a big gasp. And I think it was that gasp that allowed the lungs to begin to aerate and allowed the PPV to be successful. So I guess the change in operator provided a little reprieve on the downward pressure of the mask on the baby's face, but the baby with repositioning reacted to that, and I think that's actually why this baby improved. Okay, so I showed you a picture of Neil Feiner. Wade Rich and Neil Feiner worked together for years on a program similar to what I'm showing you in San Diego. And as far as using NRVR for a research tool, the quote that they always gave me, and I don't know which one of either Neil or Wade said it first, so I'll credit both of them with saying it, is the question isn't what should we study, it's what should we study this week? Because there was so many ideas and so many answers that they could get from watching the videos from again a QI and education perspective that would generate hypotheses for study. And so again, PDCAP changing from purple to gold precedes an increase in heart rate. And now it wasn't the only person that has published this result. George Schmolzer was a fellow at the Royal Women's before I was, and a PhD student at Monash, and he did a much more comprehensive, much better study than what we produced that described the same relationship. Okay, so another study question. I've alluded to in that first video my puzzlement at how a vigorous baby goes apneic. Vigorous preterm baby goes apneic, and can we avoid the baby from can we avoid inducing that apnea? This is an example of again an extreme preterm baby who is vigorous at birth, and then after the application of the face mask becomes apneic, and then becomes bradycardic. And you can see there's a decent amount of blanching around the baby's face, and that's nobody's fault. It's really hard to apply downward pressure enough to get a seal, but not too much where you don't provide that decent amount of force. Anoop Katheria published a paper that did have video of the resuscitations, 150 babies that were under 32 weeks. He was looking at resuscitating on the cord versus not in that particular study. And the interesting thing that came out of it was the amount of babies born less than 32 weeks who breathe spontaneously at birth, as well as the rates of positive pressure ventilation in the delivery room. And he's not the only person to describe these numbers. Locally at Monash, we've had a QI project led by Callum Roberts and hosted by Stacey Lowe that showed similar results. So question for you at home, you can answer this to yourself, but spontaneously breathing at birth for babies less than 32 weeks, it's 91%. There's other studies that have put that number down as low as about 85%, but somewhere between 85 and 90% babies will breathe spontaneously at birth that are very preterm and extremely preterm. Yet 2/3 of these babies get positive pressure ventilation as part of their stabilization. So the question is why? Why are the babies who are breathing spontaneously end up going apneic and needing positive pressure ventilation? One working theory, which is quite a good one, is does a face mask stimulate apnea by the trigeminal nerve reflex, which is reflex that when a fetal or newborn mammal becomes hypoxic, their vocal cords they'll become apneic, and their vocal cords will shut in response to this, making non-invasive respiratory support really, really difficult. The trigeminal nerve reflex is also stimulated by downward pressure on the eyes and face. So in a study done by the team at Leiden and by Coopers et al., application of a face mask resulted in apnea in 50% of the time in babies less than 32 weeks. And then in a preclinical study of rabbit pups, which we're seeing the video clips of here in phase contrast X-ray imaging that was done by Jess Crawshaw and led by Stuart Hooper, what we can see is 2 rabbit pups, one with a stable breathing pattern, and aerated lungs, and open vocal cords most of the time, versus an unstable breathing pattern in a rabbit pup with no air in the lungs or very little, and mostly closed vocal cords. So the connection between levels of obstruction while we're providing non-invasive respiratory support hasn't previously included vocal cords as one of the places of obstruction. We think about airway in the sense of the tongue and the positioning of the neck, and maybe if you're thinking more advanced, you might also be thinking about lung liquid as being a level of obstruction. But the vocal cords are also a potential barrier to providing non-invasive respiratory support successfully. Again, the team in Leiden also has described the percent of time that during positive pressure ventilation in apneic infants less than 30 weeks, what percent of the time those infants have their vocal cords open or closed using ultrasound. It's a pilot study. I think there's 20 babies in it, but it was pretty convincing that this relationship that we see preclinically also exists clinically. That in babies who are getting PPV for apnea that were less than 30 weeks, the vocal cords were shut 90% of the time, whereas in babies that were breathing spontaneously, the vocal cords were shut only about 50% of the time. So that led to a RCT that we have finished collecting data on, and is in preparation for submission, called the Fondue trial, in which babies less than 32 weeks were supported with either face mask CPAP or nasal CPAP at birth, and we used a primary outcome of needing positive pressure ventilation, yes or no, with the idea being that the babies who started on nasal CPAP, which you can see in this example here, in this extreme premature baby who was provided nasal CPAP actually on the cord in this particular case, and then shifted over to the resuscitator, which you can see here. This is a perfect example of it. So we're 3 minutes into this birth. The baby is breathing just fine. They're about to turn on the light from the resuscitator in just a second, which is, again, this was a great resuscitation, and the light could be on before it started. So little lessons always to pick up on. And you'll see the heart rate and stats will come in. The baby's got a great heart rate. And so the result of the Fondue trial was that the babies who started on nasal CPAP required statistically less PPV than the babies who were started on face mask CPAP. So we needed, CPAP was successful 58% of the time versus 39% of the time. This relationship held up for the smaller babies. It doesn't mean that there aren't babies that don't require PPV, but it does make you think, is if there's a different way to provide CPAP, which is less stimulating to the trigeminal nerve reflex, maybe there's less support that we need for these babies. Okay, so let's move into, in the last few minutes before we move on to questions, the beginning of our journey to show that neonatal resuscitation video review is actually an effective tool for training. So we've shown so far that NRVR is feasible, right? So the next step is to show that it's helpful and psychologically safe for learners. And then moving further down on this investigative track, and this list of goals came from a conversation I had with Peter Davis about how to incorporate this tool and validate it. But it also fits really well with the Kirkpatrick's New World Order educational model, where the next step up the pyramid would be showing that NRVR improves individual and team performance, and then ultimately improves clinical outcomes for our patients. So I've been lucky enough to work with Associate Professor Arnaz Kumar, who's an obstetrician at Monash, as well as someone who has an expertise in simulation training and education, medical education. And in 2023, we were joined by a very talented honor student named Zoe Weimar, who's now gone back into her last year of medical school, as well as Sam Best, who's an equally talented nurse educator at Monash. And then we had two internationally recognized education experts, Deborah Nessel in Sydney and Alexis Batista, who works with the military in the US, to help us evaluate qualitatively our NRVR program. So what we did was interviewed 22 nurses and doctors via semi-structured technique, transcribed the interviews, de-identified them, and then analyzed these interviews with a social constructivist viewpoint, and then coded these interviews to identify consistent themes and report those themes. There were 4 main themes that came out of it, and I'll show you examples of these themes. So the first theme that came out that was consistent from most of the participants was that NRVR allowed them to learn from reality. It allowed them to practice their clinical appraisal skills, even if they were sitting, at a table rather than being actively involved in resuscitation. It still provided some increased level of activity. So this is a still shot from the same video of a baby that's dusky and pink. And a quote from one of the clinical nurse specialists says, "You see the baby on the screen go from blue to pink. And you see what's worked. You see how that team has interacted and responded, what's worked well and what hasn't. It's just more, I think, real life and relatable to a lot of people." The second theme was immersive self-regulation. One of those sub-themes was improved time perception. And this is one I am definitely in lockstep with the opinion, and it's very eloquently stated by this registrar when it talks about having the ability to understand how time is passing during a resuscitation. So the quote is, "I think it's good to dissect," meaning the video. "You can go a lot slower when the facilitator pauses, like, what was happening here?" And then you're like, wait, there's a lot more happening than we can actually process in real time. We actually get a sense of like time. Sometimes time moves very strangely in a resuscitation. For me, reviewing the videos is helped me understand how long it takes to do tasks, which is a pretty simple thing. And how long it takes for the baby to respond to the various changes in management, increasing pressure, oxygen, whatnot, changing operator, that we do during the resuscitation, and how long I would expect for that to happen, which allows my thinking to be a lot more clear and intentional. Okay. Learner psychological safety is an obvious question to ask. It's confronting to watch yourself on a video. Potentially it's confronting to watch a video in general. What we found was that what it really did actually, NRVR really does promote psychological safety because it reduces fear of the unknown. Instead of wondering what worked, what didn't, how well you did, how well you communicated, you now have an objective record that can tell you. And most people ended up feeling much better about how they performed after watching themselves on a video than if they hadn't seen it. And on the flip side, if things didn't go so well, at least now you know, and you know what it was that you think you did well and didn't do well. And this is all in the context of coaching, not just, putting someone out on their own. But anyway, here's a quote from a fellow that says, "I hate it watching self on video, but I've trained myself to be more comfortable with it. I mentally know that it's good for me and it will improve what I do. And so, yeah, I think it's just a matter of like forcing yourself to do it. And then it's actually not as bad as you think." If you watch the movie Sully, and I think this was true to life because Captain Sully in an interview that I read, did say that after he landed the plane on the Hudson, he was conflicted about his choices for days, despite the fact that all the passengers got off the plane safely. He was honored to know whether or not he did the right thing, whether he'd just gotten lucky, whether there was other alternatives. And through the review process, he was able to come to closure and conclusion in peace at what he had decided to do. And he also learned some lessons for hopefully something that will never happen again. But I think, it's a good example of how probably many pilots have learned a bit about emergency management from that example. And that goes nicely into the second quote on the page, which is from one of the more junior nurses. And if I had been played that video back before I had done anything, I would have been a lot less scared to go to deliveries. And definitely that was my sentiment when I was faced with these CDH bursts that I'd never seen before. Okay, impactful group dynamics was the fourth theme, which was benefits from multidisciplinary input. So one of the clinical nurse specialists really appreciated how we had a multidisciplinary group reviewing the video. So the quote is, "I like to have a multidisciplinary group rather than just nurses teaching nurses. It's good if we learn to do our recesses as a team rather than you learn this and we learn that, and then you're supposed to work together when we get to it." So then if you're reviewing, we need to review it as a group, as a team as well. Now, we tend to split the doctors and the nurses up at Monash when we do this. You know, having me as a doctor facilitate a lesson with the nurses is some means of multidisciplinary involvement, but it's something I certainly think we can improve with our program. So almost done, just a couple more slides. So in the past project that I showed you, the qualitative assessment, that was an honors project that Zoe did in 2023. Like I said, it's in submission. This year, Christina Nee has joined us as an honors student for the year. We're lucky to have her with us, and her project is looking at the benefits of neonatal resuscitation video review in one-on-one coaching sessions over time. So in this project, we have 7 fellows / nurse practitioners and 6 nurses who will carry around the cameras and try to capture videos of themselves, and they'll review resuscitations that they were involved with in one-on-one coaching sessions, ideally 3 sessions over a 6-month period. And then we'll see how they felt about their understanding and improvement through this process. The example of the resuscitation video that I'm showing here in a still shot includes a room overview that I think is appropriate for a one-on-one coaching session, because being able to understand what's happening in the room, not just with the baby, and the vital signs and whatnot, adds another piece to the puzzle of being more cognizant and aware of what's happening and how to improve clinical treatment, how to manage the team and conduct yourself in a team environment. And it doesn't really lend itself to a group session, but a one-on-one session, I think it's psychologically safe. So we're including that in the sessions for this project. Okay, so in conclusion, NRVR at Monash had generally favorable attitudes towards it, although these reviews can be uncomfortable. Generally speaking, the benefits outweigh the discomfort. And for what it's worth, this is a group of fellows and nurses and registrars who've been, and consultants actually, who've been interviewed, who have dedicated their professional lives to improving how they're able to care for neonates. So it's not a general medical group, it's a group that's more invested. So there's a bit of bias in that opinion, but I think it's applicable to our setting. The key benefits of NRVR from a learning and professional development perspective was that NRVR is realistic, it promotes reflection, debriefing, and group discussion. So other future directions besides the project that I outlined in the previous slide, really to support other NRVR efforts in other NICUs. I know that in Brisbane, Helen Liley published a study and had a prospectively considered research project going for a couple of years, where I think they reviewed 250 videos. But I'm not sure if there's any other currently alive NRVR programs in Australia besides the one we have at Monash. But although it's rare, it's not unique. So again, in Leiden, their NRVR program, they call it NeoFlix, which I'm really jealous of how clever that name is. And they're actively publishing similar evidence that we presented about the utility of NRVR. I think another good goal would be to incorporate NRVR into formal training programs like NeoRecess, like we have for our advanced resuscitation days at Monash or NRP. And then, as I spelled out in a previous slide, demonstrate improvements in quality of patient care and improvements in clinical outcomes for babies. So thank you very much for listening to me. Sorry, I went a few minutes past the time I thought I was going to. And thank you to the Monash NICU staff, the NRVR quality assessment team, and my mentors who taught me how to do this. So questions?
Well, thanks, Doug. That was a great overview from somebody who has, who's done this and is in this, because you gave us not only sort of the technical sort of advances you had to deal with, the editing of the material, and then the analysis. You told us about the medical analysis, which you could tell when things would go better, and you could tell when things would actually go worse, which was really interesting. And I really appreciated those last slides about the educational value on different aspects, not only individual performance, psychological performance of people who have to work on the high stress situations. So I think that's a really good overview. Some questions are dropping in. Oh, I have to say, Tammy, you want to ask Doug this question?
Yeah, I can see the chat, but I'm happy to. But Tammy, hi Tammy, thanks for tuning in.
Hi, you're right. No, I'm happy to be here. I'm just wondering if there's any like legal implications if
Yeah.
you like say there's a tracheal perforation or there's a
Yeah.
baby who doesn't respond to resuscitation, or you create pneumothoraces that do badly. Like, you know, does that make you more legally vulnerable because
Yeah.
it's all documented? Or I mean, do we document things anyway, and it perhaps it protects you because it tells the full story? Just interested because I know that you know, at a lot of the hospitals that we work, we're very reluctant for families to you know, take photos even, but certainly to video during resuscitation. And I've always thought the reason for that was not just, oh, this is uncomfortable, or you might have my face on your personal video camera that you can do whatever you like with, but also that legal implication of, you know, did I not do a good enough job there? So yeah, I'd be interested in your thoughts, but I think this is brilliant what you've presented. Yeah.
Thank you. Yeah, and it's a pretty obvious question. It's the one that I've gotten most commonly whenever I presented on this topic. So we sought legal counsel before we started the program at Monash, and the advice from the legal counselor was that the videos would be protective, probably more protective for the hospital than anything else because it gave an accurate, objective record of what happened. I think the safety though from the clinician is that, again, it's a very accurate record. And from my understanding, legal implications occur with negligence more than understandable mistakes or even just differences in judgment. You know, it's appropriate to go upon pressures in certain situations, and my understanding is if that leads to a pneumothorax, then that's a consequence of being born prematurely or needing resuscitation that's advanced. So yeah, so my understanding of that is it would be more protective. We haven't had any legal issues per se. This does segue to another question about parental consent. So I guess I'll just touch on that, Kurt, in the context of this answer. We have a mechanism if parents ever ask to watch the video. And so that was something that we got advice from Helen Lively about when she did her project. So we don't need parental consent for this at all. It's a waiver of consent. The videos that I did show, I did get additional parental consent. I went and told them, you know, there's been this video and I want to use it outside of the Monash Health sphere. So you get like a release of photos or videos, the kind of thing you would get for publishing a paper where you wanted to show an example. So for the videos on this talk, those have had additional consent. And our mechanism, which again borrowed from Helen's experience, was if a parent requests to watch it, then we would do it chaperoned with, in this case, with Alice Stewart, who's the director. That I believe happened, Helen Lively told me that happened once in her project, and it was a woman who had given birth via a general anesthetic C-section. So wasn't basically mentally present at the birth of her child and just wanted to see what it looked like, which is more of a heartwarming story than anything else. But so far we haven't had that. We did have one occasion where a video camera got stolen, and there was a video of another baby on it. So we had to do disclosure about that. So we make extreme efforts to get the videos off of cameras once we have the recording done. But that's happened once in 5 years. So there are some risks to it, but certainly it seems that you can incorporate mechanisms to mitigate those risks.
Look, at the other two questions are very similar. I think you addressed them both already. I have one. It's a bit of a broader question. You looked in detail at so much resuscitations, and you also work with animals by studying resuscitation. And our resuscitation guidelines are updated every 2 years or so, and the changes are ridiculously minimal. Now, is that what it is? Should we change a bit faster with all these new ideas and knowledges, or should we have this slow pace?
Yeah, it's a pretty interesting question because there's both sides of the coin, and one of the potential issues with changing the resuscitation algorithms, so they're generally a one size fits all, right? From your 22 weeker up to your 42 weeker, with very little derivation, which is convenient because it fits on one card essentially. You know, it's essentially it's a respiratory emergency that may have some other things to it. So that makes it simple. It's hard to argue with the speed at which things have changed because, you know, 99% of the time, plus we leave the delivery room with a baby who generally has decent heart rate and stats. So, and there is a responsibility to show improvement over what we are currently doing in order to change it, with the perspective that the initial algorithm was based off of as much expert opinion as anything else. And then since then, a lot of those experts have taken upon themselves to try to answer the questions and provide the evidence for that initial approach to resuscitation and train people like me to take up for them after they've retired. You know, and it's also a space where we don't have a particularly large specialty. There's not many of us out there, so it's incumbent on all of us to try to answer some important questions, the questions that we think are important that will improve the care of the babies. So I feel pretty privileged to be in the position to try to help improve how we're taking care of babies. But, you know, on the flip side, Kurt, there have been some pretty dramatic improvements. Like the Helping Babies Breathe program is just like a phenomenal example of an adaptation of, you know, NRP specifically, I guess, and ILCOR recommendations that have decreased stillbirths and improved morbidity and decreased mortality in resource limited settings. So yeah, it probably doesn't move as quickly as I'd like, but you know, there's been some pretty good benefits to what we're doing already. Almost to the point where it makes me think, you know, how much more can we actually improve on what we're doing and show it statistically in big, meaningful outcomes?
Well, yeah, that's probably my point. So people ask for a big trial during resuscitation, which is so hard to do. George Smolser wants to do something with sustained inflation, which physiologically makes sense, but a trial like that is never going to happen. So we're never going to get that evidence. But I saw you using video laryngoscope during resuscitation at birth, you know, although we have some studies, but there is not much evidence, but it just makes so much sense.
Yeah.
Have a visualization tool, whether for the operator or the supervisors, you know, sometimes it just makes sense.
Yeah.
Yeah. All right. There's one more questions about, you know, if the video has ever been used for a personal performance appraisal, like individual performance appraisal, more like a test.
No, yeah, no, they haven't, but you know, we're at least not formally in a punitive perspective. Certainly, if there was a concern, again, our mechanism is to, you know, I would escalate it up to Alice, and we discuss it probably at a level that's either appropriate to stay within the unit or gravitate above. But you know, the things that I think you can really be faulted on for something like neonatal resuscitation is less so decision making and more so poor preparation. You know, and we do have an algorithm that we're supposed to generally follow. If you deviate from that, usually there's really good rationale. You can